Good afternoon and welcome to our continuation of Connecting the Dots. Today we're talking about eye health and sickle cell disease. And today we will have with us Dr. Kaiawa Clarke and Dr. Rajrishi Sharma should join us a bit later. Right? We're going to be discussing some important issues with sickle cell, optical issues with sickle cell disease. I know most of us have known or have heard of retinopathy, but we're also going to explore some other complications that persons with sickle cell disease can have. So, Renee, you could go.
Hi, sorry about that. So I will introduce Dr. Clarke. Dr. Kaiawa Clarke is a fellow of the International Council of Ophthalmology and has worked in the field for approximately 9 years. He is an acting registrar in the ophthalmology department at the Port of Spain General Hospital. In this role, he provides ophthalmic care for patients with a wide range of ocular diseases, including sickle cell-related ocular complications. Dr. Clarke is currently a final year resident in the Doctor of Medicine Ophthalmology postgraduate program at the University of the West Indies and wishes to continue his subspecialty training in the field of glaucoma. Dr. Clarke, the floor is yours.
Hi, good day. Thank you very much again for inviting me.
Dr. Clarke, if I may, I just wanted to disturb you and ask you to say something nice about you.
Oh, sure.
A couple years ago, and he was one of 2 doctors who saw me when my sight in my left eye was giving issues because of my disobedience, I would add. However, through him and the gentleman who will be joining us later, Dr. Sharma, from having 0 eyesight, he referred me to Dr. Sharma's clinic, follow-ups and all that kind of good stuff. 3 or 4 years after, I have maybe 90, but he can tell you because he has a good memory. My sight is probably 90% plus. And I want to thank you publicly for, I'm just see clearly now according to the song. And I continue to do the things have been suggested because when Dr. Sharma comes in, I'll say that about him, but following the advice of the people who care for you, especially when you don't understand it and you may disagree, and getting advice from other people is really important. So again, thanks a lot.
No problem, no problem. I guess all parts of the day's work, I guess. So thank you again for inviting me to have this talk. I know usually people tend to stick on the retinopathy point of it, but I'm glad you asked me to talk about some other ocular complications of sickle cell. So today we will be talking about orbital disease and high femur in patients with sickle cell disease. So, there we go. Okay, so we'll just go through a little bit of anatomy of the eye, just to make sure everybody's on the same page of what things are where the eye is in location to the skull, so that we understand exactly what we're talking about. Then also, we're going to discuss the role of sickle cell disease in the eye and why is it that patients with sickle cell disease have these particular complications. And then we'll go into the orbital complications and high femur. So as you all know, sickle cell is a group of inherited red blood cell disorders. And unfortunately, it is really a legacy of the transatlantic slave trade brought to us from our ancestors in Africa. And outside of sub-Saharan Africa, the Caribbean has the greatest prevalence rates of sickle cell disease. And as such, we see a lot of the complications associated with it. So where can it affect the eye? Everybody knows about the retinopathy in the retina and the vessels, but it can actually affect almost all the structures of the eye. In the conjunctiva, it can cause small infarctions. The conjunctiva is this clear skin on the outside of the eye. The anterior chamber, which is the front clear part of the eye, which we're kind of looking at right now, seeing the iris here. this it can be blocked with sickle cells, causing the pressure in the eye to go up and subsequent glaucoma. It can affect the iris, as seen specifically in this photo here. The bottom picture is a normal iris, and the top picture is a patient with sickle cell disease where they've had infarctions of the iris leading to these whitened areas here of the iris. Retinal vessels, as in terms of retinopathy, it can affect the optic nerve because of decreased blood flow and even complete blockage of flow to the optic nerve. The choroid is the main vascular layer of the eye, and as such, we know that sickle cell affects the vessels, so they can get problems with the choroid. And the orbit, which is the surrounding bony structure of the eye, which, although uncommon, can still be affected. So just to get an idea of what we're talking about in terms of orbits, because you'll hear me mention some terms about preseptal and orbital, the eye sits within a bony compartment made of many bones, as much as 7. And within this bone compartment, you can see are the muscles that help to move the eye. The nerves also have to give a sensation to the front of the eye, allow us to move our eyelids, and the major nerve which allows us to see. Now, as you can see, part of the eyeball is exposed outside of this bony protective wall. And this is the part of the eye that we normally see, the nice white part that we look when we look at everyone's faces. And this area outside is actually separated from the area inside by a thin membrane here called these very sensitive tissues, especially the nerves. So, and how does it affect the eye? Well, it really affects the eye the same way it affects everywhere else in the body. It can either be through infection or infarction. So what is that? Infection, patients living with sickle cell disease have immune system dysfunction. It can be innate, resulting from the cells being a bit slow, sluggish flow, difficulty for the cells to be brought to the areas of infection. And also in childhood, patients, especially with SS and sickle cell, they lose their spleen early in life. And the spleen is plays a very vital role in being able to deal with particularly bacterial infections. So this predisposes patients with sickle cell disease to myriad of infections, especially in childhood. Then the other part of it is infarction, which is tissue death due to lack of oxygen. So essentially in sickle cell disease, there's decreased oxygen carrying capacity. Blood doesn't carry as much oxygen because the red cells don't live as long. And because of this, the tissues are a bit starved for oxygen, and it can come to a critical point where you can get infarction. And this usually shows up in most patients complaining of painful crises. And this can affect anywhere, particularly the bones. There's increased susceptibility to bony infarction due to the sluggish flow. And we see it most commonly in the hip, where we get the vascular necrosis of the hip. But as I mentioned before, the eye is surrounded by at least 7 bones, and any of those bones can be involved in an infarction process. So this brings up the important point of infection prophylaxis, especially in children. And this can be done by various methods, which have been employed in various Caribbean countries, Jamaica, some parts of Trinidad, Barbados, and Vincent, where they have neonatal blood screening. So we can identify patients with sickle cell early o'clock so that they can get the necessary screening and monitoring for infection as in childhood, moving on to adulthood, antibiotic prophylaxis to help prevent these infections, especially when they're in those critical years when they don't have the spleen and exposed to lots of pathogens, and robust vaccination programs. So back to the eye. So infections surrounding the eye and the orbit are just divided into preseptal cellulitis, meaning in front of the septum or predominantly affecting the tissues outside of that bony orbit, or orbital cellulitis, where it can invade into the orbit and affect those very vital tissues there. So infection, preseptal cellulitis, the infection is of the soft tissue, and it's relatively low risk. meaning you're probably not going to lose your sight. It may be uncomfortable. You may have some warmth and redness as seen in these pictures here, but the eyeball itself is generally unaffected. As you can see, it's a nice white eye here. It can progress though to orbital cellulitis if left unaddressed, and therefore should generally requires oral antibiotics for treatment. In the case of orbital cellulitis though, these people tend to come in very ill. They have high fevers, they're dehydrated. The infection has spread into the orbit, so you can see there's more extensive swelling, particularly in this child here. With you can see the red conjunctiva poking out of the eyelid because everything is just swollen. And this can actually, if left unchecked, can result in a myriad of complications, including an abscess formation within the orbit, meningitis, vision loss, even death, if not treated appropriately. So this is an ophthalmic emergency, and these patients require hospitalization, intravenous antibiotics, and in some cases, they require surgery. Now, another entity which is quite unique to sickle cell disease, but can present very similarly to orbital cellulitis, is orbital bone infarction. So there are multiple reports of this in the literature where the orbital bones become infarcted occurring in patients with sickle cell disease, mainly in children, similar to orbital cellulitis. And it has a similar risk factors for other vaso-occlusive crises, so temperature, dehydration, infection, hypoxia, meaning low blood oxygen, or metabolic disturbances. As I said, it mimics the presentation of orbital cellulitis, so it really looks just like that child in the picture before. And these patients, though, may respond to both antibiotic therapy. And importantly, what is different between the two is these patients may respond to steroids, which you wouldn't want to use in a primary infectious process. And some of them actually want to require exchange transfusions. Now, orbital cellulitis and orbital bone infarction can actually progress to this problem, which is more worrying for the ophthalmologist, orbital compartment syndrome. So the orbit, because it's a fixed bony structure and it's already filled with all the structures that you need to move the eye, to feel the eye, and to see with the eye, it really doesn't have any more space for anything else. Therefore, any muscle swelling, blood, mass, or any tissue swelling at all within the orbit is going to raise the pressure in the orbit, right? So the problem with the elevated pressure in the orbit is that the blood pressure is of a certain value. And if the pressure of the orbit exceeds that of the blood pressure, you won't get any flow of blood. The blood vessels will kink off. And that can predispose these patients to retinal artery occlusions, retinal vein occlusions, optic nerve damage, and irreversible vision loss. So these patients need to be seen urgently. They would likely have presented already for either orbital cellulitis or orbital bone infarction, and they would need to be addressed, usually surgically. So that is pretty much it for the orbit in terms of sickle cell complications. So we're gonna move on to hyphema. I know it's a very strange sounding word, but it's actually very simple. Hyphema is defined as the presence of blood within the aqueous fluid, which is the watery component of the eye, the anterior chamber, which is the front part of the eye. And the most common cause for hyphema is trauma. Most common cause we see in patients, unfortunately, it's physical trauma between two individuals. It can be as small as what was seen in the previous photo, or the blood can actually involve the entire anterior chamber, which we call an 8-ball hyphema, when the entire anterior chamber is filled with blood. Obviously, the more blood that you have in the anterior chamber is the higher likelihood of potential complications. So as I said, the most common cause is after trauma, but it can also happen after intraocular surgery, whether there's damage to surrounding structures or the person is predisposed. There are other inherited blood conditions that can also predispose persons to having a high femur, such as hemophilia, von Willebrand's disease. And then there are acquired conditions due to anti-thrombotic agents like warfarin or aspirin, which can predispose people to getting spontaneous high femurs. And then there are other issues like leukemia, tumors inside the eye, severe inflammation, or as in the case with patients with diabetes and in some patients who may have severe proliferative sickle cell retinopathy with detachment, they may actually grow new vessels on the iris, and these vessels can break and bleed and cause high femur. So the problem with high femur in sickle cell, because people get high femurs all the time, as I said, we get a lot of people with blunt trauma to the eye. The problem with high femur is that that area, the anterior chamber, is relatively hypoxic and acidic. And as I mentioned before, those are some of the risk factors for sickling of the cells. So in that blood that is in the anterior chamber is at higher risk of sickling. The issue with that is that the natural fluid process of the eye, as seen in this diagram here on the left, is that the fluid is made by this structure here called the ciliary body. It passes between the lens and the iris, comes through the pupil, and drains through these channels into the vessels, into the conjunctiva, and into the bloodstream. Now, if we have sickling of those blood cells, as here, they can actually block those channels. And therefore, the fluid that the eye is making is not able to drain from the eye. Therefore, it's like you're constantly pushing water into a balloon. So the pressure inside the eye is going to get higher and higher. And one of the problems with high pressures in the eye, similar to high pressures in the orbit, is that it can kink off blood vessels and cause stop flowing in the back of the eye. But the other problem is high pressure in the eye has been associated in many patients with damage to the nerve at the back of the eye. And that very particular nerve damage is called glaucoma. But obviously this is a special type of glaucoma that you will develop here. Another way it can cause problems is if the blood clots in the pupil, meaning it's blocking the drainage, the ability for the drainage of the fluid to get through the pupil, as seen here. And this causes the fluid to build up in what we call the posterior chamber here, and pushes the iris forward. And then the iris will block up the drainage channels, and then the pressure will suddenly rise. And that can cause people to present in very painful glaucoma called acute glaucoma. So these are situations which are quite unique to patients with sickle cell disease once they have blood in the front of the eye. So as I said, you can get raised intraocular pressure and vessel occlusion, which can either be the vein or the artery. And if you get vessel occlusion in your retina, the vision will suddenly drop, and sometimes it won't come back. Optic nerve damage can occur with this high pressure. And finally, corneal blood staining, meaning that the pressure, which is seen in this photo here, the pressure in the eye is so high that it's forcing the blood cells into the cornea, and they stay there. It actually lasts for many years and may not ever fully clear. So corneal blood staining is something we try to avoid. So how do we avoid these problems with high femur in patients with sickle cell disease? So all patients who present with medical care, because sickle cell is so prevalent, whether it be the trait or full-blown sickle cell disease, it's so prevalent in our population. All patients who present for medical care with high femur should be tested for abnormal sickle hemoglobin. All right. Generally, most patients who don't have sickle cell disease and have small amounts of blood in the front of the eye, it will resolve on its own without complication. And they may just require conservative treatment, which means that they sleep with the head up to allow for the blood to settle to the bottom so that they can see over the level of blood that is there, and allow it for the body to reabsorb that blood, and
Dr.
avoid
Clarke.
any medications which might promote further bleeding, such as aspirin and NSAIDs like Olfin and ibuprofen and those kind of things.
Dr. Clarke.
Now, the problems come in when we have high pressures in the eyes. We have to treat these patients because the high pressure can cause damage to the retina, damage to the nerves at the back of the eye. And patients with sickle cell, because of the low oxygen carrying capacity of the blood, there are increased risk of damage in these cases. Yes, SPC, you were saying something?
Oh, Mr. Blackman or Mr. Ezil has a message.
Sorry, I can't hear you. 1 second.
Mr. Blackman has a message for you.
Just give me 1 second.
No, yeah, no, Dr. Clarke. I just wanted you to
yes, I can hear you now.
You hearing? I just wanted you
yes,
to
I can hear you now.
I just wanted you to reiterate the fact that you said that persons with the trait as well are susceptible, because I think that is something that is often missed. And
yes.
I'm not aware that persons with the trait go to regular screening or they're referred for any reason.
Well, people with the trait, they are at risk of sickling because they do have, it's an autosomal, what we call an autosomal dominant trait. So you generally inherit things from both your mother and your father. And when you have an autosomal dominant disease, if you inherit one from mom or one from dad, it will show up as part of the disease. As opposed to if it was recessive, you need to get the gene from both mom and dad. So with sickle trait, they do get sickling of the blood cells, but it's by far less than that in patients who have the full-blown sickle cell disease. So the problem is those patients can still get sickling in the front of the eye because the conditions in the front of the eye are quite good for promoting sickling of the blood. It's low oxygen and very acidic. So even those patients with sickle cell can get sickling, but it's not near to the extent as those patients with full-blown disease.
Thank you.
So back to, right, so the high eye pressures, patients need treatment, particularly those patients with sickle cell disease. But the problem is that you have to avoid quite a few of the medications that we would normally use to treat high eye pressures. So drugs, like some of the patients may be on these drugs already, so I put the names of the drugs here, Cosopt and Trusopt, Diamox and Mannitol, all actually worsen sickling in the eye and can worsen the problem with the blood in the eye and problems with the pressure. So we try to avoid these drugs in patients who have high femur with sickle cell disease. Also, usually when the pressure is high in the average person, we would say if it's above 50 millimeters of mercury for about 5 days or greater than 60 millimeters of mercury for 2 consecutive days, we would intervene surgically. But that threshold is much lower for patients with sickle cell disease. So if it's higher than 25 millimeters of mercury for 24 hours in someone with sickle cell disease, they will probably require surgical intervention to relieve the problem. And what does surgical intervention entail? We go into the eye and we wash out the blood, right? And it's indicated with patients with total high femurs or blood staining as well. In young children, because they're now developing vision, and in order to develop vision, you have to be able to see. High femurs take some while it's clear, and if it is impairing the vision, you may opt to wash it out earlier in young children to prevent them from not developing proper vision. So, in summary, sickle cell disease predisposes patients to a myriad of unique eye complications. I couldn't go into all of them today, but we did discuss 2 which are of particular importance. Orbital disease, which occurs mainly in children and is potentially sight-threatening. And the most common cause seen after trauma, high femur. And anyone known with sickle cell disease and high femur should seek medical attention to prevent further complications. And anyone with high femur should be tested for sickle cell disease. That's it. Thank you. So if you have any questions or need any clarification, I'm here to field any questions.
So, Dr. Clarke,
Yes.
a sty on the eye or on the eyelid, that would be an orbital issue?
So a sty would be an infection of the eyelashes, and it can progress to preseptal cellulitis. So that infection can spread to involve the rest of the lid. In patients who are immunocompromised or have dysfunctional immune systems, that can even further progress to orbital cellulitis in some cases. But mostly, it usually resolves on its own or with oral antibiotics. So it's treated like we would treat someone with a pre-septal cellulitis.
So that in essence is a serious condition that
It is not so, as I said, pre-septal cellulitis, even in patients with sickle cell disease, is a low risk infection. And it's generally cleared by the body's immune system with the help of oral antibiotics. So my advice would be, if you do have a stye, many people like to try to play around with it and try to pop it or burst it. I would advise against that. Warm compresses alone will probably help it to rupture on its own. And then after that, definitely antibiotics to help ensure that the infection doesn't spread to involve the rest of the leg.
What generally causes that?
Hi, yes?
No, I was just
go
asking
ahead,
what
Kieran.
generally causes a stye?
A stye, so it's an infection of the eyelash follicle. So usually you can get sweat and oily debris covering the base of the eyelash follicle, and the eyelash follicle will also has glands around it which secrete sweat. So when you get the covering of the base of the eyelash follicle, it causes stasis of the substances within that eyelash follicle. And essentially what happens is stasis of any liquid or sebum or anything like that is just food for bacteria. You know, they love those areas. And eventually bacteria will replicate there because it's ideal conditions for them, and it will cause an infection.
Okay. Go ahead,
Okay.
Renee.
Right, I had a question. So when Dr. Waveney Charles was alive, she used to drill in her patients to see an ophthalmologist once a year. So I wanted to know if you also recommend that, and also it was to pick up bleeding at the back of the eye. So I'm not clear what is that about? Is it for the glaucoma you mentioned, or any of the other conditions you mentioned here today, or something special, something else?
So I actually didn't mention it intentionally because I think Dr. Sharma is going to touch on that a little later. But yes, the most common condition that we see patients for in the eye clinic is sickle retinopathy. And what that essentially is the retina is, if you think of the eye as a camera, the retina is the film which will sense the light and then send that image down the connecting channels, which is your optic nerve, to your brain so that you're able to see. And the retina, because it's dealing with a lot of light, it's very metabolically active. So it needs lots and lots of oxygen. So the eye is actually one of the few organs that has some of the highest blood flow rates in the body because it's so metabolically active. So in sickle cell, the cells can sickle in periods of hypoxia or full stress. This can block some of the vessels in the retina, and those then get starved of oxygen. And because they get starved of oxygen, they send out signals. The body is always trying to fix itself. So the same thing with the retina. So they send out signals asking for more blood because we want more oxygen. So they send out signals with a substance called VEGF. And that signal causes new blood vessels to grow. But these new blood vessels don't grow like your regular normal blood vessels. They're put down very quickly. They're very friable. They break very easily. They bleed. And then when they go away, because sickle cell is these new vessels in sickle cell retinopathy actually auto-infarct on their own, meaning the sickle cells then go and block those new vessels as well. They then leave scar tissue, and scarring can pull on the retina and cause it to detach. So patients with sickle cell disease who are at risk of sickle retinopathy are at risk of sudden loss of vision, which is through bleeding from those new vessels and retinal detachments. The reason that you need to see us so often is because if we detect that the sickle retinopathy is progressing very rapidly, we can actually intervene and treat to try to reduce your risk of suddenly losing the vision from the vitreous hemorrhages, from bleeding in the back of the eye, and from the retinal detachments. So, but sickle retinopathy kind of works in the opposite way that sickle cell works for the rest of the body. So if patients with HBSS, right, sickle cell, tend to have the HB thal, tend to have the more severe vaso-occlusive crises and acute chest and the other extraocular sickle cell complications. But in the eye, it's actually the opposite. The patients with SC tend to have the more severe retinopathy than the patients with the SS. And it's because those patients with SS only get the new vessels, but then the sickle cells then go and auto-infarct those new vessels, so they don't cause much of a problem. That answers your question somewhat.
It does, it
But
does.
I'm sure
Thank you.
Dr. Sharma will go in depth into that when he comes.
Okay, so I see there's two questions. What is the surgical procedure or treatment for orbital compartment compression shown in a previous slide?
Right, so the problem with orbital compartment syndrome is that the orbit is closed. So the pressure is building up inside the orbit and causing problems. So in order to relieve orbital compartment syndrome, you have to open the orbit. And they can do that by many different incisions, but the premise is the same. They cut into the septum and open it up. And if there is an abscess there, which is taking up space, they will drain the abscess. If with the infarction, there was some bleeding that went on and caused a hematoma, they will evacuate the hematoma and leave possibly a drain for any further fluid that may collect there that takes up space and increases pressure to drain from the orbit. So that would be the treatment for orbital compartment syndrome.
Okay, and another question from Denise. At what age can you test a child with SCD eyes? I guess test a child with SCD, yeah. What age you can test their eyes?
Test their eyes. Well, so in children, I believe there's a national drive for testing children. I think it is a year they're supposed to have their first eye test. But you can actually test a child's eyes first, you know. We can determine if a child is able to see or not. But with sickle retinopathy, it's unlikely that they would have had any retinopathy before the age of 5 years old, and definitely before the age of 6 months, because it takes about 6 months to lose all your fetal hemoglobin, which is the special hemoglobin you have in mommy's womb, which kind of protects the children from the complications of sickle cell within that first 6 months. But definitely at a year, any child can be tested, and probably after 5 years for sickle retinopathy.
Okay, anyone has any other
Just ask
questions?
if anybody in the audience has any questions. You can raise your hand.
I'm sure Dr. Sharma will touch on that.
I want to, as we wait for Dr. Sharma, let me share. So Dr. Clarke just explained what happened to me, because I'm fortunate to live with sickle cell SC. And lots of times we are told that we have the milder type. But guess what? When it came to eyes, I was out front. And I also had a Dr.
Mr. Young,
Clarke.
1 second,
Yes?
Mr. Clarke can stop sharing his screen.
Oh, sorry.
Dr.
Yes.
Clarke, yeah. Sorry, go ahead, Mr. Young.
Yeah, so to emphasize the importance of checking your eyes every year, from my late 20s. And this is something I've done with the lady who's visually impaired, who does these sessions at the Port Spain General Hospital. Very big, resounding voice. Can't remember her name now. Miss Agar, I think is her name. Right. So she lost sight and she talks to people about it. And she hadn't mentioned all, it's just all about sickle cell disease and what I was dealing with. Because remember, I was between Port of Spain and San Fernando. Tobago, actually 3 hospitals to me, Port of Spain, San Fernando, and Tobago. So what had happened is that I was checking my eyes, I have my glass change, and this, I guess, optician from Ferrous sent me directly to a specialist at the time, Long Circular Mall, who instantly ushered me off to Port of Spain Hospital. This guy was he consulted, was an Indian guy, real good. And within a week, I was having lasers done. Thereafter, my instructions were minimize the amount of physical activity in terms of raising the pressure in your head. I'm just using very simple terms, okay? So I did that for many years and not really understanding what was going on. But I think just before the bleed happened, I came to the clinic and I was told everything is fine now and I can revert to my regular stuff, trying to play strong and and kind of good stuff, doing push-ups and whatever have you. Within 2 years, I had my first bleed. I went to the hospital. One of the peers saw me and they couldn't find anything. I wasn't very happy. Went back to my stuff within another, I talking about digging trenches and lifting heavy stones, all kinds of stuff as well. Within 2 months, I had another bleed. That's when I saw you. And it said, if the bleed doesn't clear up, that means you need surgery. Now, I hate that word, right? And there started my journey because it never cleared up on its own. And I eventually thought of Dr. Sharma, who was there in Port of Spain for one clinic. And next time I saw you all, I saw you a lot of times, but I saw other people on the team. They said, Dr. Sharma is back in Tobago, so either do it privately or you go all the way to Tobago. I'm saying like all the way to Tobago. Well, I live there, so that's fine. And, with the diligence of you guys at Port of Spain, and tell me how urgent it was. And if it can't go to Tobago, you have to get it done like yesterday. But the thing is that you all don't make anything like that sound as a big deal, You're so calm. Well, you, there's Dr. I think his name starts with Agostino or something like that. You will just feel relaxed, But then I realized that, it was serious. If I could go blind, I could be permanently blind if this thing isn't dealt with. So I'm in Tobago. And the first time I met Dr. Sharma, he mentioned something that you mentioned very quietly. The body did not clear it up on its own. And he explained to me that the system is so built, our body is so built that injuries to the eye, for example, if it's not really bad, the body can handle it on its own. And it clears up. And that's why when I went to the A&E, by the time I got there was nothing to be seen. The second time, nothing to be seen. By the third time, I guess I did too much. And then he explained to me the presence of the small blood vessels that would appear when the large blood vessels are blocked by sickling cells. And once the crisis has completed, the blood cells will start flowing again to regain flow to the retina, but those small blood vessels remain. And they're the ones that can break easily and cause it. So that's what I took away. That's how I explain it to people, because you all give me all the intense information. I fund down and I make it simple. So is that accurate if I continue? Is that description accurate? Right.
Oh, so far so good.
Right. So, but I benefited from 4 different things. So before the bleed happened, I was having vision like this, and then vision like this. Good. And one self-corrected. Guess what? One in the left eye didn't self-correct. So when Dr. Sharma went in, by the time he went in, there was a cataract because of how long the blood was there. He had to fix the bleed. He had to fix the pull on the retina and give him a new something, a new lens. So, so he's saying, and I want to repeat this when he comes in. Again, very matter of fact. Listen, I can't guarantee anything. My team and I will do the best we can, but if you follow instructions, you will get what you deserve in terms of eyesight. If you don't, then that's your decision. That's just this man talking to me like 10 minutes before the operation, right? He said, I want to talk to you now. That's it, you know, settle down and go get the operation. So the day after, I'm recovering in Tobago, and I have family saying, no, the doctor said me look down for 2 weeks, literally look down. Can't be, I'm going to all the detail, call you know how I've shared, but they told me to look down, and family members tell me look up, friends tell me look up. All I mean is that if you want your eyesight back, and they do what you tell you, you get most of your sight back. So I said, okay, I look down, in spite of what all of that they told me. Then I go back to the clinic. Another gentleman is there who had the operation, who had an operation the same day with me. So we back, I think, the second day. And I'm sitting on the chair and I'm looking down, backside the pain and so on now. He said, brother, you're doing the wrong thing. You're supposed to look up. I said, well, the next time you do my operation, I will listen to you. So I tell him why I said, okay, cool. Then I want to see, when my appointment came in, the first thing the doctor said to me, I asked him to lead in. He said, you really want this side back? I said, what do you mean? He said, most people don't follow instructions. I hear it as you are looking down. He said, you can look up now. I have to look and say, he said, you can look up now. And when the examination is finished, then you go back to your position. I'm saying all this to say that in people's good nature, they try to give you advice that has been given to them. And especially if it's family members or friends who are older than you want to tend to follow it. But in this case, I would say follow your doctor's advice. If anything goes wrong, right, we know who to hold responsible, but you need to stay, putting like eyesight and ears and that kind of stuff, it's crazy because people only know that they have had experience after you sharing your experience. There are a lot of people walking around with these experiences, and you just know nobody can tell it. That, I mean, some of these members are probably hearing this for the first time, and they would have seen me when I was blind, fully blind in my left eye, you know, having a good old time driving. I could say it on here because it's legal. You can drive one.
Mr. Young,
Again,
just ask you,
the amazement of the way the body is built, because I realized that my periphery was significantly affected when I started to bump into some people, because this eye is telling me, hey, you know, I'm seeing everything, but that's the brain seeing, not the eye. And so after a couple of bumps, I realized I have to turn all the way around to see where I'm going. So driving, you know, you can't just look, you have to look all the way through, you know.
Mr. Young, let me just ask you to share what were the symptoms that you felt when you started to have that bleed in the eye? What were any changes?
Symptoms? The first thing I did, like I said, I went for a regular eye check. I was in a clinic, I knew nothing but the SISB, nothing but no any hematology clinic or anything like that. My first introduction to sickle cell disease was with my eyes, and I wish I remember this doctor's name. So through errors, I'm calling a name because that doctor did more than I expected. I was wondering why they bothering me so much. I went to the specialist at Long Circular Mall, you know, without any major explanation. If you can go to the hospital right now, so go. So I was kind of old way, so I went across and then I went back to control what had happened. No symptoms. Then I was sitting on a bus one day, and this eye, I felt like if someone was in glasses and realizing, this is more than it. When I went, they said I had a bleed. One hospital had a bleed. By the time I went to the other hospital, they can't find anything. Starting laser and all kind of stuff because of the nose that they had. When they went inside, I said, Mr. Young, we're not seeing anything in your eyes. So you have a bleed. So I'm saying, you know, this is confusing now. Fast forward 10 years after that, and the second thing happened. I guess it occurred because I need to understand why these instructions were given to me. This was like probably 25 years in the past.
Okay.
So even though I had no issues for all those years, if you are inclined to have it, you have to pay attention. So when it bled, it just bled. I had no warnings or anything like that. And it bled and it cleared up. When I went back to normal life, bled and it cleared up again. The third time I said, no, you kind of hard.
All right, so Stacey has her hand up.
Clear it up. Sorry?
Stacey has her
Stacey
hand,
has her hand
so we
up.
can allow Stacey to.
Okay.
Hi, good afternoon, everyone, and good afternoon, Dr. Clarke. Thank you for joining us today. Dr. Clarke was one of the surgeons that did one of my eyes when I had to do surgery in 2018, I think it was. Based on Kyle's recommendation, he told me that these people could go in and do your eyes there. And I was really skeptical with the public system because everything takes really, really long to do. But the treatment was really, I think, on par with possibly private institutions. After the earthquake, however, things got a little slower, and I had some issues after surgery because I had a bleed at one particular point in time, and I have floaters at this point. Dr. Clarke, is there anything that could get rid of floaters? Would time heal all wounds, as they say? And in my left eye, I think there's like a glare that usually, I don't know, something like, you know, you always see like a flash of light on my right eye. Is there any reason that might be happening now?
Okay, so there are a few things that you brought up there, so I'll try to address all of them. With respect to the floaters, a floater is just something in the eye that doesn't allow light to pass through it and cast shadows on your retina. So with that definition, then a floater could really be anything. Okay. But considering the sickle cell disease, one of the concerns of floater is a bleed. So, but usually with a fresh bleed, many people will say that the floater is red, and they will see it, the shower of blood with those floaters. But many people do get floaters just with age. As we get older, the jelly in the back of the eye, it condenses into a solid and a liquid, and the solid starts to cast shadows. The difference with that type of degenerative floater is that it doesn't get worse. You don't see more and more and more of it. It stays pretty stable. Most people can even tell me what shape it is. They will describe it as a shape, and that it's always there. Sometimes even after cataract surgery, because we disrupt the whole lens and jelly interface, you can get floaters that way. So those floaters, the degenerative and the post-cataract, generally, if they don't go away, most people get so accustomed to them being there, it's just like having another hand, you know, that's just part of what their day-to-day life is.
It's kind of annoying because sometimes all of a sudden now, like this black thing just passed and I'm thinking someone is passing or...
Yes. So some people though, if the floaters are very, very severe, they do try to opt to do surgical intervention, but that warrants that possible complication. So most people don't actually do surgery for it. But the main concern with someone with sickle cell, I would be concerned about is this a bleed? The other question now with respect to flashes, so flashes many times accompany floaters because the flashes are related to retinal stimulation. So the retina can't feel any pain, it doesn't feel touch or heat or any of that. The retina can only sense light. That's its only job, that's all it can do. The problem is that if anything stimulates the retina, it will interpret it as a light. So as we are getting older, and as I said, the jelly starts to contract, and and it pulls away actually from parts of the retina where it was previously attached. Most people that is without any symptoms, you don't have any problem because it's so loosely attached. But some people, it can be very firmly attached, and when it pulls on the retina, it can stimulate that area of the retina, and it's perceived as a bright flash flashing down these corners of the vision. Eventually, once the jelly pulls off the back of the eye, it will stop. Sickle cell disease, though, is that you have these potential new vessels and scarring and fibrosis, which can cause the jelly to be very firmly attached to those areas and can risk retinal tears and subsequent retinal detachments. So my only advice really for you would be that you really need to get someone to look at the back of the eye to determine what is the cause of the floater and what is the cause of the flashes to determine if it's something that needs treatment.
So the floaters were because of a bleed, but when I came back to clinic, they said that it had cleared up, but the floaters persisted after. And with regards to the flashes, because it's in the other eye, I didn't think or anything of it. I thought it was just in relation to the surgery, possibly lens kind of move or something like that. I'm not too sure.
Well, at first when you had mentioned glare, I was thinking that it was a lens issue. And sometimes after you have cataract surgery, the bag that we put the lens in can just get a little bit cloudy, and we can do a laser to open that up. And that usually causes glare, like when you're in the bright lights, you get a lot of problems with glare. But then you said it was flashes. So flashes more is usually a retinal issue. Sometimes it can be light just hitting the edge of the lens that we put in, but most times it's a retina issue. And considering that we're talking about sickle cell, I would say that it's better to check that it's not a retinal issue than anything else.
Okay, thank you very much, Dr. Clarke.
No problem. And just to answer again about that question with test the eye for sickle cell disease, I kind of misunderstood what you were asking me. You want to know whether to check to see if they have sickle retinopathy. That can be done, usually advised after the age of 10. 10 years old, you can start looking to see if there's sickle retinopathy, significant sickle retinopathy.
Okay, Dr. Clarke, I was surprised actually when you mentioned the part about COSOP and the eye drops like that causing sickling, because my mother is diabetic and she has to use COSOP. So I was wondering if you have sickle cell disease and you are diabetic, what there are alternatives if you need to use an eye drop like that?
COSOP is for it's a glaucoma medication, and it's not a problem once there's no blood there. So normally there's no blood on the inside of floating around in the water of the eye. So in that case, it's not a problem. And the COSOP, because it's an eye drop, is less likely to cause any systemic problems. I mean, very little of it gets into the system, the body, the rest of the body. So it shouldn't really be a problem for her unless she has a high femur.
Okay. Anyone else has any question?
Dr. Clarke, can you expand on the presence of von Willebrand or prevalence in Trinidad and Tobago?
That's beyond my scope, you know.
No, but have you seen other people, as you mentioned,
it is possible. It's possible because it can cause bleeding.
But have you seen anybody with that condition?
But
No,
we haven't had many people coming in with spontaneous high femurs that didn't have an obvious identifiable cause. So it didn't really require major investigation because they had an obvious reason for why they would have blood there. For example, the trauma, or patients with diabetes who had new vessels growing on the iris and then it starts to bleed. So those are the kind of people we get coming in with high femurs. And in those cases, even if they did have von Willebrand, it wouldn't make much of a difference in terms of the management of the high femur. Sickle cell is unique because it makes it worse. So it can be a problem. And in terms of von Willebrand and hemophilia and those kind of things, the real concern really is that after it clears, it might happen again. Or when you do surgery to clear it, it might happen again. So that's the real concern there. But I can't say I've seen anyone specifically that has problems with von Willebrand. I don't even think I've seen anyone come in the clinic personally with problems with hyphema from hemophilia either.
The reason I asked is that the society advocates on behalf of 3 other blood disorders besides sickle cell disease, those 2, and of course thalassemia.
Right.
So you've seen people with hemophilia, I assume?
Very few. I think I've had one person who was referred for a problem, but it wasn't with respect to bleeding at all. It was completely separate and apart from their hemophilia.
Okay, all right. But if your peers ever discuss or disclose that they found people with von Willebrand, once it's okay professionally, probably you can advise the society, because I don't think we know anybody really living with von Willebrand. I've heard of cursive remarks about people having an aunt or so, but not the way but the reason I'm asking is that Dr. Wavy Charles, has always said that von Willebrand is the most common. It's more common than sickle cell disease, but it's highly misdiagnosed, so that's why it's the least known. So of all the 4, there are more people with von Willebrand than anybody else in Trinidad and Tobago, but it's least known because of its high level of misdiagnosis. So
definitely you have sent me
talk about it and all, let us know. Sorry?
Definitely now you sent me to do my homework, so I'll have to go and check, and I can get
that's based on Dr. Charles. I'm just speaking after what she has said.
But to tell of the population that may be and other complications of it, I've been in eyes for about 9 years, so I haven't really been seeing much of everything else for quite some time.
Okay, Dr. Clarke, well, we haven't heard from Dr. Sharma yet, so in the meantime, you could just expand a little more on sickle retinopathy and what it is, because I know that's the thing most of us know that we go at a clinic for, right? And we don't always completely understand what it is. And
to add to that, can you also talk about why it's really good trusting the clinics, why Stacey has had that experience on how Dr. Sharma stands and his team in terms of intervention? Tobago especially, why is Tobago such a special place for them to be?
Okay, so we'll start with the sickle retinopathy. So essentially, as I mentioned, everything related in terms of complications with respect to sickle cell, it has to do either with the low blood oxygen carrying capacity, the sluggish flow of the blood cells in the vessels, and the sickling itself. So in the person who has normal hemoglobin, the blood will flow easily through all the vessels in the eye. It flows arteries, goes through the thin capillaries. It releases its oxygen into the tissues to allow the tissues to live. And then the deoxygenated blood goes back via the veins through the circulation to the lungs to do it all over again. In sickle cell, there's abnormal hemoglobin. So in the oxygenated state, the blood cell maintains its normal round configuration. So it moves around nicely. But once it loses the oxygen, the hemoglobin, because of the way the hemoglobin is made, it changes the structure of the blood cell. It forms this sickle shape. So the issue in the retinal vessels is that these sickle-shaped blood vessels don't move as easily through the blood vessels and can cause blockages. So once you have a blockage, that area will be unable to obtain oxygen for a period of time. And it may be that blockage may be there long enough that short enough that it's relieved before that tissue dies, so it can regain its function, or if the blockage is enough, that tissue will die. So when that tissue is still alive, but it's at its critical point where it's starving for oxygen, and it will send out chemicals and signals. Those signals, the main one that we know of is called vascular endothelial growth factor, or VEGF for short. So you might hear people talk about that. Will cause new vessels to grow. And these new vessels, by growing new vessels, it's attempting to bring more blood to that area. And by bringing more blood, it will bring more oxygen. The problem with sickle cell is that the sickle cells then also block up those new vessels, and those new vessels form scar tissue. So in patients with SC, where the sickling is supposed to be less, the sickle cells don't block up those new vessels as well. So those new vessels don't autoinfarct, and they continue to grow all in the edges of the retina, which is the most starved for oxygen. And that's why patients with SC tend to have more prominent retinopathy. They have more, the retinopathy is the new vessels that we see growing. We actually can see it when we look at and examine the back of the eye. So patients with SC tend to have more of those new vessels with blood in them growing in the back of the eye, because their bloods, they don't have as much sickling as someone with SS. So therefore, those new vessels won't get blocked off and autoinfarct. And therefore, because they proliferate more, they involve more of the retina, and therefore can cause more problems. So that's why people with SC tend to have more issues. In terms of the treatment, most times for sickle retinopathy, we can observe, especially in patients with SS, simply because their sickle cells will block up those new vessels and cause them to be no longer flow of blood and no longer proliferate. It may proliferate somewhere else, but that area will stay stable. With patients with SC though, we have to then treat the areas with the new vessels, because they won't autoinfarct and those new vessels will continue to grow, causing problems like bleeding, recurrent bleeding, and retinal detachments. How we treat it is we actually kill the retina. We cause burns with laser to kill the retina that is not getting enough oxygen. And that works by two ways. By killing, and this might sound morbid, but if we had 50 people in a room and it was locked and there was only a limited amount of oxygen, if we killed off 49 people, that one person left back will live longer than if we had all 50 people in the room. So it's the same practice. We kill some of the retina to require less oxygen and therefore decrease the amount of chemicals that the retina is sending out, calling for the new vessels to grow. But then on top of killing that retina, we also kill the cells that release the chemicals that call for the new vessels and cause them to grow. So when we're looking at patients with sickle retinopathy, they can be through a spectrum where we can see either they have big new vessels, they have areas of bleeding, they have new vessels that have infarcted and just look white, or they have just areas that are scarred and left with scarring. And mostly with patients with SS, we will see them on further down the spectrum with the scarring. So we don't really have to intervene much with them. But patients with SC, once they have the new vessels and they're proliferating and they're growing like wildfire, we have to do something, or else they will come in suddenly with loss of vision because of a bleed or something like that. In terms of the treatment ability within the scope of Trinidad and Tobago and sickle retinopathy, most clinics, they have eye clinics in all of the regional health authorities. So there's Port of Spain in Northwest, in North Central is Eric Williams or Mount Hope. In Eastern, there's Grande. In Southwest, there's San Fernando, and Togo is the right Scarborough. So, but in all the clinics, I believe in all the clinics, there's the ability to do laser treatment, which is the least invasive treatment for sickle retinopathy, where we make burns. But if it requires any further intervention, so if there's a bleed and they require surgery to remove the blood, or there's a detachment and they require surgery to fix the detachment, that requires one specialist expertise or a vitreoretinal surgeon, and it also requires specialist equipment to do it, of which that equipment, as far as I know, is only available in San Fernando and Tobago. And the expertise currently is only available in Tobago. I think.
Can you repeat that, please, Dr. Cha, about I like the song of that. Please tell us again.
So essentially, if you have sickle cell retinopathy that requires surgery, you get done in Tobago and in San Fernando right now. So, but if it is before that stage where it's proliferative and it can be treated with laser, I believe you can get that done in any of the regional health authorities. And the person who does it in Tobago is Dr. Sharma. So I don't know if that has answered the question or if there's some things I need to further clarify.
No, that answers the question, because I never asked him, but he's quite involved in even the outreach in Tobago.
Mm-hmm.
And more so, I know I saw him once in Port of Spain, and then he was back in Tobago. But the other question, is there some specific problem in Tobago why a team like his is there in Tobago? Was it just that it's both islands?
I actually don't know.
No. Okay.
I'm not sure. Dr. Sharma did work at some point in time in Port of Spain, as you had mentioned. Yeah. We didn't have the equipment for him to really fulfill his duties. So I'm not sure why they chose Tobago as the main area. I can tell you, based on the research that I did with the newborn screening, they did do newborn screening in Tobago, and Tobago has very similar prevalence rates of sickle cell as Jamaica and St. Vincent, where about 15% of the population have the sickle cell trait, right? So that's quite high. So I don't know if on top of that, with the other reasons that they might need vitreoretinal surgery, they decided to use Tobago. But that's just me speculating. I don't know.
Are you saying that the equipment is lodged in Tobago and San Fernando?
Yes, there is in Tobago and San Fernando. It's very expensive equipment, so that may be the reason why they taken the approach of having a specialist center. So in medicine, when there's a need for something, and there's a need for specialist expertise, one way to improve on specialist expertise is to have that expertise in one area and have everybody with that problem come to one area. It works twofold. One, that person sees a lot of the problem, so they get very, very good at it. And two, you can have the equipment in one place, so you don't have to buy equipment in each place, and it will be more efficiently used if it was in one place. So that may be the reason why the regional health authorities have done that in that way. But again, this is me speculating because I don't actually know.
Great.
Okay, thank you.
No problem. I'll ask some hard questions.
But with sickle retinopathy, as you said, that the retina itself we don't feel anything.
No,
so,
you don't feel anything.
So what essentially what would you advise patients that they should look out for if they may be having an issue developing? What is there anything that could guide them in terms or because you can't feel it.
Right. So this is the same problem that we have with glaucoma, and we have with diabetic retinopathy, is that you don't feel it or get really any major symptoms until it's advanced.
Yeah.
So the only way to pick it up in those cases is screening. So that's why it's advised for yearly screening, especially for patients with SC, so that we can pick up a problem before it becomes a major problem.
Yes.
With respect to symptoms though, as Stacy had alluded to, one of the more common problems that patient comes with sudden floaters because of a bleed. So if you notice that you have floaters, or the floaters are getting worse, meaning more, you're seeing more and more, or they have a color, you see them that they're red, right? There's blood. It usually means that you've had a bleed, and you should be checked. One, because you could have had a bleed, but two, bleeds can be associated with other problems like retinal tears and detachments. So it's good, once you see that you have a bleed or floaters, you should be checked. The other issue is when you get a hemorrhage in the back, sometimes the vision can get very hazy. So any sudden loss of vision, sickle cell or otherwise, you should get that checked with urgency. So those would be the two main things. Sudden floaters or sudden loss of vision, definitely to get checked. But outside of that, yearly screening.
These floaters have a set size?
No, they can be any size or shape. The only thing that can tell you that for sure that's blood is if it's red.
Okay.
But sometimes it will just look dark. It will just look black. And you want to be able to tell there's a color. But
because I mean, I had an issue at one point, well, recently, where I could have swear that I saw a floater, but it didn't last very long, right? And I only saw it under certain conditions of light, right? Like it had to be a bright background, a white background, or it had to be out in the open, right? So in a dark room, I wouldn't necessarily see it. So I mean, I went to check my eye one time, but they didn't see anything. But it's like a couple other days, I swear I saw it. But the thing is, it comes and it goes. It doesn't stay, right? And then obviously, as you say, it's a floater. So if you look for it, it disappears.
Yes. So the reason why floaters tend to come and go is because the jelly in the back of the eye is mobile. So as you look left and right, it swishes around in the back of the eye. So most people, when they're not trying to look at the floater, it tends to come into their vision. But when they try to look at it, because the eye moves, it pushes the floater out of the main visual line of sight. So they don't see it. So that's one of the reasons why people tend to have floaters that come and go. Coming and going is not a major problem, but if you see them enlarging in size or enlarging in number or amount, then that's concerning.
Okay.
Thanks for that, because it's easy, you know, especially as you don't feel anything or experience anything, it's easy to lapse with your yearly appointments, as I sometimes do. So this emphasizes the importance.
Yeah, well, some places actually don't require screening. So if you look at the United Kingdom guidelines, probably because the rate of sickle cell in their population is much than say ours or they don't actually require screening. What they suggest is just to present when you have a problem, because usually when there's a significant enough problem, a bad floater, sudden loss of vision, people will seek medical attention. But I have found in our population, not just related to sickle cell, people will tend to sit down on vision loss at home and wait for it to come back without seeking medical attention. So one, because of the culture in our population, I think screening is beneficial, but two, the prevalence of sickle cell, because of the prevalence in our population, I think screening is also beneficial.
A lot of people are squeamish with regards to their eyes as well too, because even with me and having to do surgery, I think the day of the surgery, my pressure was like sky high, and I had to be relaxed because the first time I did the surgery, they did not give me the medication to calm me down or whatever.
Right.
And I was like so nervous. I could do surgery anywhere else, but you see the eyes, I don't know. And worse again, you're up.
But somebody offered to stay with Stacey and keep her company, and she just bluntly refused. No, I'll do it myself. Thomas is joining us, and I just want to ask a question. After surgery, aren't floaters more prominent? That has been my experience. I never knew floaters before laser surgery.
Well, it depends on which surgery, what surgery you had done. So
I had laser surgery, and after that it was like all this stuff.
yes, they can be more prominent.
That was that's when they're trying to stop the
laser.
Yeah, laser to
when
stop
you had laser for the retinopathy. It probably is not related to the laser, but more related to the retinopathy. That you had continuing floaters. Because if you required laser, that means you had significant enough sickle retinopathy to cause a problem, and that can result in Dr. Sharma's here. That can result in further small bleeds that you may have had that resulted in the symptom of floaters that you're having. So it may not have been the laser specifically, but actually the retinopathy for which you had the laser, which was the reason that you had the floaters.
Dr. Sharma, welcome.
Hello, hi.
Hey, Dr. Sharma.
Hi, how you all doing?
Great. We're glad to have you.
Sorry to join so late. I was operating today. I have one case to go, but we're waiting for that. So I said I'm gonna join quickly.
Okay. Well, we were just trying to learn a little more about sickle cell retinopathy, right?
No problem. I see Dr.
You want to
Clarke.
repeat the question?
I'm sure he would have given you a good insight into it.
And enough bullets.
Were there any specific questions? Or?
Mr. Young, you want to repeat your question?
Doctor, the question I had with floaters. Let me just put on my camera so you can see who I am, Dr. Sharma. You put.
Yeah, I know you. Yeah.
You dig up in a couple of years ago. And thanks again for the results. So we were discussing the but I don't remember having floaters before I had my first set of laser, and I had lasers in both eyes within 2 months. They saw the potential for bleeds. My question is, can floaters be more prominent after laser surgery?
It can do. I mean, the reason you're getting laser surgery in the first, I'm sure Dr. Clarke would have covered some of this, but the reason you're getting laser in the first place is because you have abnormal drive for new blood vessels to grow in the eye. And we're trying to diminish that drive by treating the part of the retina that isn't getting the amount of blood it needs. It may be that's a few new blood vessels have grown. And when you do the laser, you do get some contraction of the laser burns. And if you have one or two small capillaries that are fragile, that are new vessels that have grown, the contraction can cause them to rupture slightly and get a few drops of blood in the eye. So it's not unusual to get a few floaters from that. They should clear up and go away because the eye has a good propensity to remove blood from it when it gets the chance. You do remember too that you have a jelly in the eye called the vitreous jelly. And as we age, part of that aging process is for the vitreous jelly to break up. And that's what gives everybody their floaters, not just people with pathology. And so it could be that having laser and a bit of contraction causes a bit of jelly to loosen a bit more. And you're then aware of a few of those floaters. So it's not an unusual phenomenon. If you do have it and you do report it to us, which you should, then of course we'll check the retina to be sure that no harm has come to you from another bleed or from an abnormal cause. But it's not a very unusual thing. And most of these, though, should subside. Or I say subside, it may not go away because the jelly in the eye doesn't have anywhere to go. It stays there. And so you become accustomed to them, and so you notice them less. So as far as you're concerned, it subsides, but it doesn't actually go anywhere.
And CFANs is another term I heard before. I have no idea what those are. Can you explain?
Yeah, so when you get those with sickle traits or sickle cell disease and so on, when you get sickling, the capillaries towards the peripheral part of the retina, there is tissue at the back of the eye that processes light. You can see the peripheral part do your navigation and vision. The central part does your detailed vision. So the blood vessels in the peripheral part of the retina are somewhat smaller in caliber than in the central part. And if you get sickling and so on, and you get those peripheral blood vessels that are blocked, then the tissues that are supplied by those vessels are devoid of blood and energy and nutrients. And so in an attempt to continue to survive, you develop something called collaterals, which is the kind of opening up of blood vessels in the retina, which are not normally used, or you could develop new blood vessels, which is what we don't want really, the growth of sublingual vessels. And the shape of them tends to be of the collateral vessels tend to be in a kind of looped appearance in the peripheral part of the retina. When you look at them, they look like a fan, and so they're called C-fans and so on. Most of these will occlude though from clotting of these abnormal red cells, and then they sometimes bleed. You get a sort of intraretinal hemorrhage, which is where these blood vessels are. The retina is a 10-layer structure. And if it bleeds into the retina, you get these blotches of blood that the common term for them are salmon patches, because they look like a sort of salmon patch or a sunburst. And if it is that it happens deep in the retina where the pigment layer is, then it can look slightly darker. And so there are all these appearances that you can see, and people refer to as these different names, but that's what C-fans, sunbursts, and so on.
Okay. Now, when you operated, you gave me a lot of information, and of course, I selected those that stood out to me, like, keep bending for 2 weeks and no warts in the eye, no baths, and all that kind of good stuff. But explain to me why you said depending on what you saw inside, you put a gas in my eye, and I couldn't fly, and somebody else may not get the gas and that kind of. Can you talk a bit about it?
So the intraocular portion of the eye, the vitreous cavity, is normally filled with a gel called the vitreous jelly. When we need to operate on the retina, we do what's called a vitrectomy, and we remove that vitreous jelly. So that gives us free access to the back of the eye, which is the retina. When we finish surgery, that cavity can be filled with various what we call tamponades to help the eye heal. So in the simplest form, we may fill it with a gas, a acting gas, and that creates a surface tension so that the wounds that we make on the eye wouldn't leak, and so you don't need to put stitches and so on, which allows for a faster healing. And that's in the simplest form. If you don't need any aids in the eye to help the retina heal. More often than not, that could be air, and could go away within a week to 10 days. But if we're not stitching the ports and stuff in the eye, if you then bend or lift, or do something strenuous, even if you were to hold your breath now or cough, you'll feel the pressure in and around your eye sort of goes up. And so if you don't stitch these wounds and you do things like heavy lifting and bending and whatnot, then it may leak, and so you get a soft eye, and a soft eye means that you can have problems with bleeding in the eye and all that sort of stuff. So that's the simplest form of using gas. If we have tears in the retina, or if we have blood vessels that we've cauterized, you'll know that if you cut your finger or something and you press on it and keep it dry, it stops bleeding and it heals very quickly. If you keep wetting your hand and getting it washed and so forth, then the edges of the wound is sort of swollen and sloughy, and it keeps bleeding, and it takes a lot longer to heal. And if you fall and say graze your elbow, that heals within a few days, because you can keep that drier a lot quicker than you can keep your fingers and so on. So if we have bleeding in the eye, we can sometimes use gas to keep the area dry so that it heals a lot faster. And most bleed and rupture blood vessels and that sort of stuff will heal within a week to 10 days. So if we put a gas in that acts for a couple of weeks, it gives you the best chance of healing and not bleeding further. If the retina is torn, we use the gas for the same reason, to keep it dry so that scar tissue can form quickly and off the tear in the retina so that you don't get retinal detachments and so on. If you have a large area of retina affected, so if you have a giant tear in the retina or a massive blood that's bled and continues to bleed and so on, then you need that tamponade to act in the eye for a lot longer than gas would, because most gases, if not all, will be eliminated from the eye through the blood vessels. They're absorbed through the blood vessels and they go away. And depending on the concentration of gas we use, we can set it to last for anywhere between a week or 10 days to up to 8 weeks, but it will go away, leaving less and less tamponade in the eye. If we need a long-acting tamponade for a big bleed or for a large retinal detachment, then we will put oil, silicone oil, and that will stay in the eye until we do a second operation to remove the oil. And so it will give us the support for the retina or for the blood vessels that you need until you heal. Of course, we monitor that in clinic to make sure the retina is healing well or the blood vessels stop bleeding and the blood's cleared. And when that situation has arisen, then we will offer an operation to remove the oil. So the two broad as to where we use gas. Really, gas is a temporary measure. And oil is for more long-term or long-acting measure. Sorry, I think you're muted because I'm not hearing you.
I'm just testing to see how much whether you tell your clients to look down or look up, because I was sharing earlier that one of the gentlemen that you operated on the same day with me, we were chatting before the operation, then we met at the clinic a couple days after, and he's saying, you need to look up, brother, you can't look down. I said, well, I said, the day when you do my operation and you tell me to look up, I'll look up, but the doctor told me to look down, and that's what I'm going to do. So can you explain the difference in the instructions?
Yes, so the retina, it's sort of, if you imagine it as circular or clock face, for want of a description, so that you can imagine and think about what we're saying. If you have breaks in your retina or bleeding in the retina that you want that gas or oil to tamponade, and if you imagine a clock face and you think of where 3 and 9 is, then anything above that, you can have your patient sitting up and the gas or oil will float upwards and tamponade any breaks or bleeds in the upper half of the retina. If you had breaks below 3 and 9 o'clock, then you have to position the patient such that the tamponade will support that part of the retina. Now, it's not possible if you have a break at 6 o'clock, it's as a clock face, if you imagine, it's not practical to hang somebody upside down for 2 weeks, because that has problems in itself. So what you do is you get them to either look face down or lie on one side. And you can imagine that if you lie on your left side, for instance, what was 12 and 6 o'clock will become 3 and 9 o'clock, or on your opposite side, so that you get the tamponade to work the way you want it to. If the breaks or bleeds are right at the middle at the back of the eye, what we call the macula, the center of the retina, then we get patients to look face down so that the gas or oil will float upwards and keep the center part tamponaded, so we get the effect we want. So it really depends where in that clock face the breaks are, that you position the patient to get them for the bit that you want tamponaded to be as elevated as you can, so that the gas or oil can have the desired effect.
Yeah, that explains why I had to sleep on my back and sleep on my left side or something like that. So those are two instructions I just remembered. Okay, well, I mean, because what you said to me that time is once you follow my instructions, you should get a good quality heal.
Yes.
I guess that all this detail wasn't gone into because of me recovering and you have other things to do, but it's interesting to hear this, and I'm hoping that people who are listening would be able to that's for that one thing, follow instructions of the doctors when it comes to this.
Yeah, as I say, I mean, I might have said to you myself, but I say to most patients that the operation is part of the treatment. Okay, in that you have to put the retina back where it belongs, and you have to put something in the eye to hold the retina in place. But just as important as the operation is the positioning. If we want you face down, or we want you on your left side or your right side, or lying flat on your back, if you're not using the chemicals we put in the eye, the gas or the oil, to hold the retina in the position we want, it's not going to stay where we want it. So that part is vitally important, and that's a big part that patients have to play in getting a successful outcome.
that sort of exhausts my questions. That's the sense of remembering not having to wet my eye. I guess that will be part of that same explanation of, being part of the healing process, correct?
Yeah.
Or
So, well, yes. I mean, so we ask people not to wet the eyes because even in the cleanest water, you think running in your shower or whatever, there is still a lot of bacteria. Your gut and your body has defenses on it that will protect you from being infected by these things. But if you have a wound on the eye that a drop of water carrying this bacteria can get in, you can get infection inside the eyeball. And that's usually very difficult to deal with because the eye has something called blood ocular barriers. The ongoings in the eye is slightly different from elsewhere in the body because you have clear tissues and so on and to allow light to pass and vision to happen. And so if your immune system, your body's defense system had access to the inside of your eye, we would recognize it as having a different physiology, a different mode of operating than other parts of the body, and it attack it and destroy it. So you have these barriers in place to prevent your immune system from these problems. But the converse to that, get in through a wound on the eye from us operating, then your immune system can't get to fight that either. And the bacteria is then sitting in a place where nothing's attacking it, and it can multiply and cause quite a significant infection. So getting the eye wet and dirty and stuff, we say don't go into the garden and don't play with your pets or anything at all like that, is really prevent infection and control infection.
So Dr. Clarke, Dr. Sharma, sorry, before you came on board, it was asked, well, we heard that the equipment and the skills are only available in Tobago and in San Fernando, and the question was why is that so?
There are many reasons, to be honest. The training to become a retinal surgeon is a very lengthy process. You have to do what Dr. Clarke's doing, which is finish your basic training, and then if you decide to subspecialize in retina, then go on to do that. And it can be a couple of years, 2 or 3 years. And if you add up all the training, so you do 5 years of medical school, a year or 2 of interns, then let's, for argument's sake, say you get into an ophthalmology program straight away and you don't have to do a couple of years in between. And that could be anywhere between 5 and 7 years to train as an ophthalmologist. So you're looking at 5 to 7 plus 5 to 7. So you're looking at 10 to 14 years of training, and then going on to study retina, which could be another 2 years or even longer. It takes a long time to train a retinal surgeon. And the number of people going into it, people have other priorities in life, and they have life. They want to have families and they want to do other things and so on, and study for 15 years. And the other aspect of it is the cost. The machinery and the equipment and the tools to do the trade can be very, very expensive. So to set up a unit takes a lot of effort in terms of resources as well as time and training. And so it's not unusual that in a population of this size that you have maybe 2 or 3 units that can do the work. To give you an example, I trained in the west of Scotland, which is Glasgow. Some of you might know where that is, but Glasgow has a population of 5.5 million people, and there are 4 retinal surgeons and a fellow. So I was the fellow when I was there and then became a consultant. So there's 4 or 5 retinal surgeons to serve that 5.5 million people. And that unit is set up in the Tennant Institute, which is in the west end of Glasgow. And there are many hospitals you could go online and see, but there are about 15 hospitals in and around the west of Scotland and Glasgow area that do ophthalmology and have ophthalmology departments and do all aspects of ophthalmology. But all the retina work is referred into that one unit because of the cost of setting it up and the infrastructure that's needed. So it's not unusual to have a setup like that if for 2 units in 1.5 million people is perhaps average.
Okay. Well, we have 2 questions.
Mm-hmm.
What frequency should someone with SS see an ophthalmologist to maintain optimal health to eyes?
If somebody has SC disease, is that what the question was?
SS.
SS. Okay.
Yeah.
I mean, well, you touched on the different traits, you have AS, SS, ST, and S-style, okay? ST and S-style are the most aggressive types. And so they would need to be seen, I would say, maybe every 6 months, if we know that's what they have. And if they have pathology, the ophthalmologist may ask to see them sooner than that. So the less aggressive types is AS and SS, as I said. And really, they can stay on annual reviews unless they start developing pathology. And again, depending on the location of the pathology in the retina and the extent of it, you may increase that. So I guess for somebody who is asymptomatic and has been screened and doesn't have any retinopathy, then a once a year is a reasonable thing. With the proviso that if they then get a crisis of any kind, then they need to be seen at that time as well. Because obviously having a crisis means you had a period of sickling, and you may have had a few small capillaries in the retina occluded. Whereas that in itself may not be a problem, but that we then, with your vision or anything at all, but they need to be monitored for a wee while afterwards just to make sure they don't go on to develop abnormal vasculature or bleeding or similar. Most of the children that I get referred, usually, and this is well borne out in many studies, usually you don't have to worry about them too much until they hit puberty. Okay, so I usually rely on my pediatric colleagues to refer these children to the clinic as and when. Usually I screen them once to make sure there's no pathology there. And then they remain under the care of the pediatricians. If they get sickling or they have a problem, I would happily have very low threshold for seeing them. But once they hit puberty, then I tend to want to see them every year and sooner if they have pathology.
So is it then as you age, your clinic appointments should become more frequent?
I wouldn't just put it down to age, because you can have people will continue to age every day and every year, but that doesn't mean they're going to develop a problem. So I think you should have frequent visits, as I say, an annual visit, unless you're in one of the high risk categories, then maybe every 6 months. And at those visits, you need a fully dilated exam to look at the peripheral retina. And if there's any sign of pathology, depending on how extensive it is and where it is, how posterior or anterior in the retina, as in how near the center part of the eye or how near the periphery, then you may get seen every 3 months or every month, every 2 months, or whatever you feel is necessary, the clinician who's reviewing you. And as I say to all my ophthalmology colleagues, that non-retinal colleagues, that is, if they have patients that they see on a regular basis and then they see a change that they're concerned about, it's no problem at all to take a quick look at them and say, yes, I need to keep seeing this one. Oh, no, this is fine. Just continue to monitor and send them back if things change. But it has to be a very fluid situation, because you're dealing with essentially a chronic progressive condition that can change at any time, particularly if you get a crisis.
Okay, so someone has a question, somewhat unrelated to SCD, but they ask if have any post-COVID patients presented with ophthalmologic manifestations or ocular long-term complications?
Has any ophthalmology patient done that? That's a difficult question. So I could only answer that from the literature I've read. I haven't seen many post-COVID patients in my service in Tobago, thankfully, because the case numbers have been relatively low until recently. But in the literature, there have been lots of ophthalmology conditions reported, either post-vaccination or post-infection, from inflammations in the eyes, things we call iritis and uveitis, the surface inflammations, conjunctivitis, what's commonly called red eye, that kind of stuff. But so these have been reported. I don't think that there's any consensus to say that COVID causes this, to watch out for it. But I think at this stage, COVID is still such a new disease that what we're doing is what we do in medicine in any new condition, is we all report in and start taking notes. And then after a while, you do analyses and say, well, look, 20% of patients had this and 10%. And then you break them into age groups and whatnot. And in time, we'll map it out as to what to look for. But I think we're too early to say COVID is a cause of X at the moment with regards to the eyes.
Okay, thank you for that.
No problem.
Anyone in the audience has any questions? Not seen any hands up.
No. Good, but the other, if I could make a kind of pitch to you, the other thing that we have is that I see in Tobago, and I don't know how common it is in Trinidad, that there's I don't know what the word is, but I would say embarrassment in that young people feel like they're invincible, and you can't hold that against them. When I was young, I was probably the same. And everybody feels that you're young, you're fit, you're healthy, and so they don't want to present to a hospital clinic or be seen there because somebody might see them, or to admit that they have a problem. And particularly if they haven't got a problem, so they're seeing well, and somebody's telling them go to the eye clinic and let this man look in your eye. They get there and they have to wait an hour for the dilating drops to work, and then sit for another half an hour for me to examine them and all the rest of it. So, but if you do know that you have a sickling condition, I wouldn't say sickle cell disease, then please make the effort and get screened, because it's one of these things, and I'm sure Dr. Clarke would have covered this before, because I know he does this in Port of Spain, is that by monitoring patients with this condition, you can stave off serious visual problems very, very easily in the vast majority. If you start seeing problems arising in the eye, there are medications you can give, there are lasers you can do, injections. The surgeries, if you have to perform them, are a lot more successful if they're performed early, before things get completely out of hand. And so don't let the stigma of a disease or the kind of invincibility of youth make you think, well, I'm seeing well, I don't have a problem. If you have this condition, you know somebody that has it, encourage them to go and get screened, because it's a very, very good way of preventing them from having visual problems later on.
Yeah, I mean, stigma is one thing, but then I will say, for sick people, it can be difficult, especially if you have 2 or 3 clinics, right?
Yes.
And then these appointments take half the day or whole day. Right?
Yeah. I understand.
Yeah.
I was going to say in our unit in Tobago, I mean, we have a small unit, so it's probably practical to do this, but and you've probably given me an idea that I could speak to the adult medicine ward and say, but certainly for the kids so far, what we do is try and keep them from having time off school. Is we tend to amalgamate appointments. So when they come to see the pediatricians, they will then send them straight across to the eye clinic, and I will see them at the same time. Yeah. So that means they kill 2 birds with 1 stone, and we do that routinely for children. I expect that speaking to the adult physicians, it might be something to try and set up even once a month, so that people who really can't take multiple days off and stuff could come into some. I might actually take that on board as a suggestion. Thanks for that. But we do it for kids, so it's probably fair to then extend it to adults.
Yeah. Thank you.
No problem.
That topic of accesses in the area. I was going to ask Dr. Clarke, so I'm happy we have Tobago and Trinidad on the system. So the SISBD, as you know, all realizing. Dr. Sharma, are you familiar with the SISBD? I know you know
the what?
Charles.
With the what? Sorry?
Are you familiar with the SISBD? Society for Inherited and Severe Blood Disorders. Are you familiar with us?
No, I must confess, until you saw me in the airport and we chatted, I hadn't heard of it, and that's probably a failing on my part to know what's available locally.
No. I should have told you that when I was under your knife, but you know Dr. Waveney Patricia Charles very well. Right. So I'm going to ask you both if you all can facilitate, and you all within your control, more seamless access to your service when we need appointments, because everything that today says that we need to be seen on a regular basis. Just as people live with SC and SS, as much as people live with the traits AC and AS. So can we sort of figure out how we can have more seamless access see clinics and the frequency that we need, so we don't have delays that some people may complain about?
I would put my hand up and say I didn't think there was a problem to get into my clinic for screening. I mean, I can't think of anybody who a letter has come across our desk either from a hospital physician or private physician saying that they have a sickle cell condition, and we said, well, we're not going to see. Even, as I say, even the pre-puberty ones we see, and then say, look, you don't have to worry until this stage, everything looks okay. But you mean in like for patients accessing the hospital clinics without being referred? Is that
that is actually one of the things that could happen. I know the process is that you must have a referral letter and all that kind of stuff, but there have been people who would go maybe not to Tobago to go to clinics, and they'd have to get a month, 2 months, that kind of stuff before they're seen, but not realizing that what we're going through is critical. In fact, we have people with orthopedic issues. One is avian, and we have people getting an appointment a year down the road just to take care of a hip that has been diagnosed as having avian, and in fact, it's going to before it gets better. So I know there are people who have talked about having challenges accessing the system here in Trinidad. I'm not sure if it is the same in Tobago. I know there's a tight size of a population in Tobago as well. So if it does, we can certainly try to navigate it easier.
Yeah, I mean, and anything that we could do to help, I'm sure Dr. Clarke and myself would facilitate. I think patients presenting to the hospital without referral letters, I mean, ophthalmology and various other specialties are regarded as subspecialty outfits, and so you tend to be screened via physicians, optometrists, GPs, some route before you come in. And I think that's a hospital management. We won't be able to sidestep that and say I will have anybody walk into my clinic. So because you'll have a whole team in place that would be controlling that. But I think, barring that, I don't see me or Dr. Clarke being averse to seeing patients who have sickle cell retinopathy or similar.
Yeah, I agree. I don't think I personally don't have any problems with that. But as Dr. Sharma has kind of highlighted, it's part of it is not really moral control. It's more of a hospital administrative issue with respect to having to have a referral letter. I know for sure at Port of Spain, the patients who are seen in the hematology clinic, they have a specific form which they send to us, outlining which hemoglobinopathy they have, etc. And they usually get clinic appointments fairly quickly. And now with the advent of COVID, and since the eye clinic has moved to St. James, things may be a little bit more difficult because we're seeing much less patients than we were seeing before. But I suspect that will improve once things once we move back to Port of Spain and things are back to normal.
Dr. Clarke, who is the consultant ophthalmologist at Port of Spain? Is there?
Yeah, they have a few. There's Dr. Josh Ramkisoon, Dr. Nilesh Prasad, Dr. Nadira Mahabir, and Dr. Desiree Marie.
Okay.
Those are the 4 consultants for the 4 units at Port of Spain General.
I want to ask a question that's related to access as the issues come. So if a patient says, let's say a patient is experiencing floaters in the eye or multiple floaters, and they have a concern and they feel it's an emergency, what procedure should they follow, especially now in COVID times?
Well, for any emergency, the emergency department is always open 24/7 for anyone who has ocular emergency or otherwise to be seen. For eyes, there's someone always on call to see any patients who come with an ocular emergency. So 24 hours a day, you can always go to the emergency department. With respect to patients who are already in the clinic, if they have an emergency, usually for Port of Spain, I don't know how it works for Tobago, we have to go through the emergency department as well, even though you are a patient of the clinic. So still have to take that route generally, but there's always someone on call for ophthalmology, so you can get emergency ophthalmic care 24/7.
Okay.
I agree with that. It's exactly the same in Tobago, and as it's everywhere as far as I'm concerned, that all A&E departments will have an eye doctor on call. And if you have any emergency with your eyes, go to them. And most A&E departments will know the signs to call out for, that flashes and floaters or acute loss of vision, all these things. If you turn up with these complaints and they examine you, and they will get the ophthalmologist to come out and see you within a couple of hours usually. And that's been the case ever since I can remember, and even through lockdown, we're in a state of emergency. We go into a curfew tonight at 7 o'clock. If you have a loss of vision at 8 o'clock and you go to accident emergency, an eye doctor will come out and see you. So you know, all these things that we have in place for COVID and stuff is there to protect us all, yes, from the virus, but we can't let people come to harm from other conditions. And so emergency doctors are on call. I certainly is one of them.
Great, thank you. Mr. Asdale, you want to add anything?
No, that's it for me, I think. I really appreciate the information provided today, and Dr. Sharma taking time to chat with us, and Dr. Clarke.
Oh no, it's a pleasure for you to be here, and thank you very much for inviting me. That's very kind.
Yes, not a problem here either.
Well, we heard a lot about you from Mr. Young. I had the pleasure of meeting Dr. Clarke last year at a blood drive, and we had a very interesting conversation. And you know, that was the first time for me that I ever heard of persons with the trait suffering eye complications in a similar fashion to us who live with the disorder, right? And I found that very interesting, and I always thought that it's something that we had to speak about, right? But yeah, Mr. Young has spoken very highly about you and his experience, and his own experience when he had his issue.
That's very kind. Thank you very much. But what I would say about what you were saying before is that it's like anything, it's a spectrum of disease. And on one end, you have people that are very, very mild. At the other end, you have people that are very, very severe, and everybody's in between. And it's just a case of making sure that your net is broad enough to catch everybody when they need support. So yeah, and any feedback that you can give us as well will always help. And I will take that one back about running concurrent clinics with the adult physicians, because I think that might actually help.
I will say one thing, it's difficult not to speak nicely of these gentlemen when I can see because of them. That's all I'll say.
So I guess
we have a question.
there's one question.
I'll just really comment in the Q&A. And Karen says, I hope you both have, I hope you have both on another, I think she's meant to say, we hope to have you both on another session in the future. Thanks again.
Absolutely, my pleasure. Sorry I couldn't join from the start and stay for the whole thing. But as I said, Friday's usually my operating day, and so it could be a bit hit or miss for me. But yeah.
We understand.
Yeah.
There's no problem here. It was a pleasure.
But it was definitely a pleasure having you both, and we sincerely thank you both for taking time off your busy schedules to spend it with us and making this event a success. And I think it was a great success, right? So we thank you both for your time.
You're most welcome. Thanks for having me.
Thank you.
But I'll bid you all farewell and say enjoy the lockdown weekend. Yes. Happy Father's Day to all the fathers, and yeah, I'll be happy to attend a session if you're running them in the future again.
Great, thank you. And don't forget to join us, everyone, for the next session, Mental Health Issues for Caregivers at 6 p.m.